1:30. So welcome all to this ICB Primary Care Commissioning Committee. If anyone doesn't know me, I'm Ian Wake, the Executive Director of Adult Social Services at Norfolk County Council. I'm assuming you all know each other unless you tell me otherwise. So I wasn't going to do any formal introductions. Is that okay? Yeah, I'm hearing nods. Okay, I'm seeing nods. Okay, we've got a really agenda, and I absolutely must finish part 2 by 4:30 because I have another appointment. So I'm going to try and keep us ruthlessly to time. So each agenda item largely got 10 minutes. So if presenters are presenting, if they can keep the kind of salient points in 5 minutes, just to allow some time for comment and questions before we move on. So before we get into the main agenda, there is a chair's action around continuous professional development, and Jade Robinson was going to present this paper. Is Jade on the call? No.
I think Jade's on leave this week, Ian, but I think because the decision has been taken, it's just to ratify.
Okay.
Yeah.
So do you want to move, should we move to the recommendations then, which were about ratifying the funding for ICS primary care education training hub contract and non-recurrent funding of 210,667 and further non-recurrent funding of 10,533. Are colleagues happy to approve that?
Yes.
Taking silent. I will take silence as consent for all of this stuff. Okay, thank you. Let's move on then to for absence. Mary.
Yes, we've got apologies from Howard Martin, Executive Finance Officer for Norfolk and Waveney and SNE ICB, from Nick Stolls, the ICB Clinical Advisor for Dentistry, from Sadie Parker, Director of Primary Care in the ICB, also Lisa Drury, Executive Officer LMC, although I believe she may attend part 2.
Okay, super. Thank you. Declarations of interest, they're in your pack. Does anyone want to add anything to declarations of interest? No. Then review of the minutes and the action log. So minutes.
Sorry.
Oh, sorry.
Sorry to butt in. On the actions list, I'm listed as an NHS GDS provider. I've actually sold my practice, and I will be coming off that contract very soon. So that can be removed for the next meeting. Thank you.
Thank you, Jason. Hein?
Yeah, just to add to the absences. So whilst Howard is not here, you have James Granger. So he will be the voting member, and the same for Karen, who will can be voting member. So we're quorum, I think, is the important thing for any matters.
Thank you. If we then move to the minutes of the last meeting, so they start on page 12, can I just check for accuracy to start with? Is there anything on the minutes that people want to amend? No? Okay, if we then move to the action log, which is on page 20, there are a few that are open. You may need to help me with some of the initials here. So the first one was a strategic primary care workforce recruitment and retention program report. Owner was JR.
Yes, that's Jade. And I think the suggestion was that an update be brought back to January meeting. So that's in hand.
Oh, yeah, sorry, there we are. It says due date, January. The next one that's in progress is also not due until January. So we're happy to leave that. Then we had 2 that were open that were due for today. First was the strategic framework for primary care, AS.
Amanda Sear.
That's all been approved, hasn't it, and signed off. So the work stream report, I think, is coming back in November time for that.
Okay, lovely. So we can probably close that one then. And the GP action plan, part of our operational plan, is that picked up on the agenda? Yes. Under item 8?
Yeah.
Yeah, okay, super. And the last one that's open is not due back till January. So we can move on from those. Forward planner.
Yeah. You all have all the papers apart from the LCS paper. The lead for the LCS has asked for this to be brought in later in the year, partly because of the work that is taking place with the system upgrade that we are doing to capture the activity. So she thought it would be better benefit if it's brought later in the year once we've completed those pieces of work.
Okay, lovely, thank you. Which moves us on to the risk register. So Sadie was going to present that. Sadie's not here either.
Yeah, I'm happy to
pick that one up.
pick on that one.
Yeah.
So I'll take the paper as read, but there are two aspects in this paper. The committee is being asked to review the current risk in its form as it is at the moment. You would notice that there are no changes or significant changes since the last update. The second part of this paper is really asking for support to shift our focus from the way we've been looking at risk. I think we would like to be able to frame the risk in the context of the patient and population. So putting patients and the population at the center of our discussions, rather than actually working from a service delivery or from a commissioner risk. I think that way it brings us all together to really focus on our core purpose as commissioners and as providers. I think it's fair to say that as commissioners, our core purpose is here to plan and develop services that are safe for the population and for the patients. And that's the same interest from our doctors. They've really, and our clinicians, they really want to care for the patients. So the challenge we have is to shift the way we think and organize ourselves and frame our discussions to make sure that all the risk that we are articulating reflects our main purpose, which is the patient. But that is not to suggest that we are not going to be capturing the risk that we find in our own commissioning organization or the resilience risk that general practice has. It's just changing and framing things and looking at things in the lens of patient safety, quality of care, and also the outcomes of our community.
Thank you. Are there any comments or questions to Shepherd on the risk register? Thank you, Ian.
Thanks, Mark. Thanks, Shepherd. Yeah, I would absolutely agree. If we come back to fundamentals, we're looking at patient safety and really good with the concept of risk registers working around that. But I think the ICB as commissioners also have to recognise that that is absolutely tied in hand and glove with the robustness of providers and the current whole system strategies. So that's our colleagues in pharmacy, that's the dental, all across primary care, acting together with secondary care to provide a whole system robust and very strong delivery of patient services across Norfolk and Waveney and Norfolk and Suffolk. You'll be aware that it's 1st of October today, which brings in the new contract changes. I think I'm not going into those here and now, apart from to say that the patient safety risk that you allude to in your comments has been recognised on the national forums today. Nick Triggle from the BBC has done a very good piece, very fair piece, outlining the current patient safety risks of the nationally imposed contract changes. So I do think this is bigger picture stuff, it's whole system stuff. in concept, really good with the change of direction on risk register, but I do think we also have to recognise the external pressures, and on specifics, the extra pressures that the contract changes are going to put on whole system. Thanks, Mark.
Okay, thank you. Hein.
Thanks, Chair. Just for awareness, at the Integrated Care Board meeting last week, there was a question around the PAF2 risk, as it's known, the primary care resilience, sort of the summary risk, and particularly noting the risk score of 20 versus our target score of 12. And I think I've been able to talk to Mark Burgess on this one. So there is also an action to come back to the ICB board on sort of how this is being managed. So I support the proposed change, looking more at outputs and the communities we serve with this risk, but we shouldn't lose sight of the gap we see today and how we're addressing that. So it's more making sure that's captured for completeness.
Mark, do you want to come back on that point first?
Thank you. Yes, and I was going to say a very similar point actually, and just to add my support to this, and it's not either or. Just to really stress that point, as Shepard made earlier, it's looking at it in the wider context, particularly with the the new guidance in the 10-year plan, and thinking absolutely focusing on our patients and our communities as well. So very supportive of this proposed development. Thank you.
I think from my point of view, I was going to say something very similar. It fits actually very, doesn't it, with a focus on neighbourhood and a focus on relational practice and the transformation that we've set out. So it's something I would want to support. So the recommendations are first to approve the current risk register in its present form, and then provide comments on the proposed approach for strengthening risk management that Shepard's set out. So hopefully we've done the latter. Are we comfortable to approve the former?
Yes.
Yeah. Thank you. Okay, so brilliant. Let's move on. So next we have Director of Primary Care reports. Mark, are you going to do this one?
Amanda's going to very kindly cover this for us in Sadie's absence. Thank you.
Thank you. So this is the first time we've had a Director of Primary Care report come to the committee, and that was in a response from the committee. So we absolutely recognise that it may need to evolve in terms of its content, and presentation. So do please feedback to Sadie or myself outside of this meeting if there is anything that we can do to make this report more relevant to you as a committee going forwards, because we'd always be happy to look at that. I think from a national and regional point of view, for how we're managed as a team under our delegation agreements, the focus is still very much on equity of access, improving our understanding of where we have variation, recognizing that variation isn't always a negative thing, but we need to be able to demonstrate that we have a very clear plan to address negative or variation, or have a reason that we understand why we've got that, and that that's through the lens of that might be appropriate for the population that's looking after. Looking ahead, I think Shepard's covered, and we've had a discussion about how we assess and respond to risk. One of the other things we're looking at is what and how we contract in terms of those local services, those enhanced services for primary care, and developing in the short term a common approach across Norfolk and Suffolk. Now, we know that it takes a very long time to catch up with all the different arrangements, and we know there's some key differences between Norfolk and Waveney and Suffolk at the moment in terms of the alliances. But I think that Mark, that's something that you're very much looking at with your counterpart in SNE, isn't it, as to how we approach that. And I think there's probably quite a lot of work to be done about how, as a primary care team, we learn alongside our colleagues in Suffolk, and we look at how we make the most of the combined resource that we're going to have going forwards, and that we use that in the most effective and efficient way. And the other thing is to how we look at those national levers and expectations, which I think are towards the end of that paper, how we make them relevant to our population and how we make them work. So we need to stay aligned to the national expectations, but we need to think about how we make that work in the best way for our population. The last point is the work around the CATS tool. So that's Commissioning and Transformation Support Programme. We've had 2 meetings with national and regional NHSE colleagues who ran some facilitated sessions for us. They saw about 20 people, I think, coming together from across the ICB, who had some, I would say, very candid conversations about where we are in our capacity and capability across some of the key areas. Those key areas tend to line up to the GP action plan, which is contractual oversight, unwarranted variation, and commissioning and transformation. We've not got the outputs back from our colleagues yet, but when we do, I think we would be very happy and appreciate an opportunity to come back to this committee and talk about those, so we can get a steer on where we need to focus our efforts going forward. SNE undertook the exercise a little while ago, so again, that's something I think that we can look at to try and understand the strengths that we might have, or the areas that we need to focus on and prioritise internally in our capacity. So that's it from me. Is there anything else you'd like to know more about, or do please get in touch if there's things that we haven't covered in this month's report that you would like to see going forward?
Thank you, Amanda. So is there any comment or feedback, areas of interest you'd like to see for Amanda? Hein.
Yeah, thanks very much, Amanda. And I really like this report. I think I was one of the people who sort of encouraged Sadie and Amanda to write it, because there's so much happening in the primary care space. And if you look at individual agenda items, you may lose sort of the totality of it all. So I think this goes a long way. So my compliments for your first product. In this regard, I don't have lots of asks, but there is a reference to integrated performance report, and as you know, I think that would be a good addition in every meeting to get some key metrics in the primary care landscape, and then over time we can sort of build a picture where the pressure points are, also in a more quantitative sense. But thanks again.
Thank you. Any other comments for Amanda? Thank you, Shepherd.
I just wanted to say, Amanda, thank you for this report. It does resonate with the everyday kind of challenges we are facing in commissioning across all our 3 pillars, and it's really good to see this surface in this space. So thank you.
Thanks, Shepherd. Anyone else? No. From my point of view, I'd agree with the comments made. I thought it was a good and a comprehensive report. So on the variation point, that's a really interesting question. I think we ought to be really comfortable with a variation in the how, so how we are delivering and building our models, because different things are going to work in different communities. And I personally think we should be really uncomfortable with variation in outcomes, because that's the inequalities question, isn't it? So where we've got significant variation in access or in outcomes on things like QOF, yeah, we need to be focusing down on those to try and address that variation. Okay, in terms of recommendations, we're asked to note the report and provide any feedback. So I hope we've done that. Are we happy to note? Yeah, thank you. So we move now on to the primary care operational plan. Amanda, back to you.
Sorry, me again. So operational planning has probably reached a stage now where we've got a bit of a fork in the road. So we had the operational planning exercise across the system, of which primary care is a fairly small part, but obviously very significant in that planning. That plan has gone through. It's largely focused for us on the GP action plan now, which was agreed and signed off at the end of June. And I think the feedback from the national or the regional team is contained in that report. So we have a plan for the current year. Shepherd and I meet, I think it's fortnightly, with regional colleagues to talk about some of that, particularly at the moment, the challenges associated with that sort of national conversation about the GP contract. A lot of focus on increasing the numbers in pharmacy first, and a lot of focus on the provision of dental appointments as well. So as from next month, you should have a report that brings all of that information together. I think we know that information is reported in the various reports, but it comes out at different times and in different formats. So it's taken us a little while to work through that to come up with something that will be useful for you to have that oversight of the metrics. Looking forward to next year, at the time of writing that paper, the planning framework had just been published, and operational planning for us as an ICB and for many of our system partners is going to look very different from next year. And I think Hein is with us. You will know that those plans have to go through our board and signed off. I think it's in December, isn't it? So we had a much later timeline last year. We've got a much earlier one this year. In terms of next steps, I've had a catch up with some of my colleagues who are looking at operational planning just before this meeting. So I think in terms of next steps for the next committee meeting, and it won't be on the forward planner because we haven't known about it for long, I think there will be some things to bring to this committee if they would like to see them or whatever, is around the ICB's emerging strategy, around their population health improvement plan, and out of those two things should fall our commissioning intentions for primary care. Now, obviously, all that's got to be linked up because the plan we'll be writing will be for Norfolk and Suffolk. It looks very much at the moment as though the primary care planning will form part of the neighbourhood planning. So that's a big change, but it's certainly one I welcome going forward. So we're still waiting for further guidance from the Department of Health and Social Care on that, what that needs to look like. But that's where we are heading. So it really does feel that primary care is now very firmly in the neighbourhood space, which I think is a good thing. And I'm apologies, I can't give you too much detail at the moment because we don't have it. But it's thinking about how we engage with our communities and how we really think about our neighbourhoods and where primary care sits as part of that. And that's a big change in culture, and it's a big change for us to do. So there's lots of opportunity to work together on that, hopefully.
Huge opportunity around integrated neighbourhood teams, isn't there? And how we play PCN and primary care capacity into that. Absolutely. Hein.
Thanks, Amanda. And I think it's a great opportunity, as you say. It's good that Norfolk and Suffolk do a combined submission for this to sort of feed into a medium-term plan. I do have a concern, not just for this part, but the overall how compressed the timeline is. There's lots of deliverables and sign-off points. So my request is that I think we have Primary Care Commissioning Committee next month to sort of get a sight of works in progress. And I'm not sure whether it has to be the meeting in private or in public, where we can worry about that offline. But it would be good to have sight of where things stand. Thanks.
Thanks, Hein. Is there any other comments on this report? No, so the recommendation again is to note the report and provide feedback. We have to do that. Yep, thank you.
Thank you.
Thanks, Amanda. So that moves us on to the strategic digital report. Andrew, I'm assuming this is a UAH.
No, it's Anne Heath.
And Heath, yeah.
Oh, sorry.
Would you like me to try and call Anne if she's not in the meeting? Or is there another representative from digital here?
I think you're best off with Anne. So
Okay, I'll see if I can get hold of Anne. Bear with me.
Okay, thank you.
I'm probably happy to do my next item if
That would be really helpful, Shepherd, if you wouldn't mind. So if we can take that one. Yep. The general practice contract update.
yeah. So there are three changes that we are implementing as of today, and they're in relation to the online consultation and the YYGP, which is you and your GP, known probably as patient chatter with others. Then there's GP Connect. So I think the strategic direction is really trying to improve the access to primary care services. The online consultation, I've set out what we have done so far in trying to support practices and also to meet our commitment as commissioners. It's a very challenging shift that is being asked here. And there are so many views around it, and there's still some discussions at a national level in the background. And I'm conscious that my colleagues from LMC may have a view on this, and they may wish to express that. But what we have been trying to do is to do a stock take to get some sense of where are we as a system in terms of online consultation requirement. As of the 8th of September, we had 59 practices that had responded to the survey that we had requested, and 41 of those indicated that they believe they will be compliant to that. But that number has since improved, and it's probably higher now. I think we've had responses from probably 80 practices, and the deadline for the responses is today. I'm yet to get an update on where we are on that one. There were some practices that indicated that they were not sure, but we understand from soft intelligence it's more to align with some of the discussions that are happening at a national level. So we have assumed that based on previous pieces of work, potentially those practices are likely to be compliant. At this stage, I think it's fair to say we are at a stage of information gathering and information to understand our status. So I would not want to create a lot of anxiety around this until we've completed that information gathering stage and also listening to the national conversations that are taking place. I think on that's how far I could go, but we are looking at doing some audits to look at websites, about 10 practices starting from October, to actually understand what online consultation experience is, but we'll feedback on how we get on that. Then regarding the patient charter, I think we've done exceptionally well on this one. I think it's the test to see whether what has been set out there is now complete. I think on our website there are 3 places where you could go and see the national information around this subject. For practices, our digital team has helped to make sure that this is on the website for those practices that are funded. For the practices that are not funded, the small number of practices that are not funded through the ICB, I think it's our job to actually test that to look at whether they have included that information. But the whole idea is to try and improve that expectation between practices and their GP, which is really positive. Then the technical third aspect with the GP Connect, we are doing well in terms of the enabling of the function, which is the first part, which we've got 100% enablement. But there are other layers that we want to understand that sit behind that, and we have conversations going on at a regional level to understand some of those areas that would bring that completeness for that benefit. I think this is how far I could go on this one. This was for noting, and I guess I would add comments because I think when it comes to other technical aspects, some colleagues may have some views on this.
Thank you, Shepherd. Any comments or questions on this, Joni?
Hello, thank you very much, Shepherd. We just wanted to raise a number of points for awareness with the committee. Obviously, this is quite a high-level paper. Committee members will be aware of it's still subject to national debate. GPC are still in discussions and disputes with the government around these contract changes, and you'll be aware of the many different concerns which have been raised in the media regarding this. Just a few things to raise specifically. Around online consultations, Shepherd would very much welcome working with you on the audit to make sure that anything doesn't add an unnecessary additional burden to practices and that the information you get is useful. There are still patient safety concerns, both at a national and a local level, around the risk of urgent needs being put through online consultations and how those will be addressed. So that is still a concern that practices have. There should also be some awareness that the introduction of having online consultations open for the whole of the core hours is likely to have an impact on capacity, as workforce will need to be diverted from seeing patients to dealing with those online consultations and triaging them. And so it is quite likely that it will have a negative impact on patient experience because capacity to actually deal with the patient queries will reduce, as that clinical capacity is just dealing with the triaging of those calls, which at the moment they would actually be seeing patients. For the GP Connect, again, just an awareness that there are still national concerns about the patient safety of this. Some of you will be aware of the pregnancy coding issue earlier this year, where incorrect coding was put through GP Connect. So although the functionality might well be turned on, there are still patient safety concerns around the quality of the data coming through and the ability for practices to deal with that when that arrives in practices. The only other thing was just to check in the paper, you do refer to a patient experience contact email, and we were just unsure quite what that was, whether that's something on your ICB website or whether that's something separate, but it was just a bit unclear in the paper quite what that email was for and where it was being used. Thank you very much.
Thank you, Joni. Shepherd, do you want to respond to any of that?
Yeah, thank you. I think the other concerns, I think they've been expressed in different forums and they're still under discussion. So I think regarding the email, yes, it's an ICB email that patients could use.
Thank you. The other concerns are very much a live national issue, aren't they?
Yeah,
many cases.
Indeed.
I was listening to it on the radio first thing this morning on this program, which was very interesting. Any other comments on the report in front of us? No. So the recommendations are threefold: to note the progress made in supporting practice to meet their contractual requirements for online consultations, endorse the continued approach of combining survey, audit and direct support, strengthen assurance, and support ongoing engagement with practices to address any remaining gaps. Are we all happy to agree those three? Thank you. Okay, which brings us, have we got Anne with us now?
Yes, Anna's joined now, Ian.
Anne, welcome. So if we could circle back to your item, please. The floor is yours.
Thank you, Ian, and everybody. Thanks for inviting me along to provide an update on the digital initiatives. Lots of good news for primary care in the digital programme of work. We have now completed the GP practice infrastructure upgrade, which means that every practice in Norfolk and Waveney has got a full fibre gigabit connection, and they're experiencing much better speeds than before. We've had really good feedback. At the same time, we were able to use the new networks to upgrade the Wi-Fi available at practices and link that up to the GovRoam network, which means that clinicians that visit the practice from other organisations such as paramedics will automatically connect to Wi-Fi, so they don't need to find out the code and find the network and connect. So it just gives a seamless working experience. There's also far better Wi-Fi available for patients while they're in the waiting room, and we're also working to provide some tablet devices which would enable patients to use some of those digital access methods, or to look things up, or to have a lesson on using the NHS app, for example. We've also just completed the work to procure a new IT provider for GPIT. This is a provider who can complete the last part of the cloud journey, which will remove domain control servers from the practice, which again gives them better resilience because they're not reliant on any technology that's within the practice. Much easier should things go wrong, to fix and not have to have an engineer come out. So that is also a very positive move. I know you were just talking about the online consultation systems, and as Shepherd said, we've been working together with the delegated commissioning team to get the best system in for every practice and the way that they work. Another exciting initiative is around the digitisation of records, and working with our estates colleagues. They have identified for us a number of practices who would benefit from having the notes removed from the practice, and so they are being funded to have the records digitised and made available in the National Document Repository. This is a much better method than was used previously, where the records were attached to the clinical system, because that method meant that a record had to be downloaded and transferred. But in this one, the records are all just on the National Document Repository that can be accessed from any practice anywhere in the country with the appropriate access rules, of course. We've also been working on with some practices on ambient voice technology solutions. There's no national funding for these, so it's only where practices want to fund it for themselves. We're hopeful with the recent announcements that there will be some national funding coming along, and in the meantime we continue to invest in the automations programme. So the automation for repeat prescriptions is now live in 46 practices, and has issued over 330,000 prescriptions, which adding up all the time that's saved, that's for 1 year and 9 months that's been given back to practices. And delivering digital boost sessions. So these are training sessions for primary care and for ICB staff and anyone else that wants to join. So just helping to introduce people to the digital tools and apps that are available within Teams now. So helping people to use automations and more modern software to help improve their productivity and generally assist them in their working lives.
Fantastic. Thank you very much. A huge amount of work going on there. Any questions or comments for Anne? Thank you. Hein.
Yeah, and I always enjoy reading your updates. It's really great and practical and pragmatic progress. So thanks also to you and your team for helping to achieve that. There was a press release a few days ago that a new family feature is being piloted for the NHS app, and I think if that comes to fruition, it can really help to boost the usage rate across the land. I had just a curiosity question. Is Norfolk and Waveney at all involved in the pilot scheme of this feature? Do you know?
I don't believe so, because I haven't heard about it, but I will check with the team. We certainly do a lot of work with the NHS app team, so I'm sure we could get involved with that.
Okay, thanks.
Thank you. Mark?
Thank you, and I was going to echo thanks to you, Anne, and your team who've done some fantastic work in this space. My question was also about the NHS app, noting that 61% in the report highlights have accessed the app in Norfolk and Waveney. How does that compare nationally? And I'm thinking about our population, and while we have some older people who are very digitally capable as well, but and high and linked to that friends and family piece as well, looking at other ways that can be done. But how do we compare nationally? Just be useful to have that information. Thanks, Anne.
Yeah, we're slightly above average, so not remarkably ahead, but certainly not behind. We've done some really interesting work with Health Watch, which actually shows that it's the younger population that don't access the NHS app. I suppose because they don't access healthcare so much, so there's not so much that drives them to the app. But actually, the Health Watch team did discover some really interesting reasons from the young people about why they didn't access it. A lot to do with marketing and things that we've passed back to the NHS app team, who were very grateful to receive it. And and obviously they want it to be something that people sign up for as soon as they're 16, like you might do with a banking app or so on. So they are aware that the more you deliver via the NHS app, then the more it will attract people to it.
Thanks, Anne.
Thank you. Anything else? Oh, thank you. Sorry, Lauren. I beg your
Hello.
pardon.
Sorry, I've been very quiet most of this
On my
meeting.
screen.
No problem. I've just got 3 short points. The first one was just on the NHS app. I just wanted to highlight that in the SNE system, we have done work with pharmacies to upskill them in the NHS app, and they're currently doing a pilot during September and October where they're looking at starting conversations with people about the NHS app as stage 1. And then stage 2 is where people have actually installed the app and got themselves connected, giving them a brief tutorial about how to order their prescriptions or the other functionality that's in there. So if we are looking at NHS app uptake, that's something to consider, particularly for those who have smartphones but haven't quite got themselves connected yet. The second point was actually alluding back to what Joni was saying about GP Connect. In community pharmacy, we are still reliant on a lot of commercial-based systems that have APIs in place, and the connectivity of some of those systems it was innovative 10 years ago, but they haven't moved forward much since in some cases. So it'd be really good to have a discussion at some point around how some of the external commercial systems speak to the NHS systems, and what we can do to help navigate that and make sure that people are using the best systems for patient safety and for their connectivity, particularly when we look at things like flu season and national booking services versus private systems that process patient data. And then just the final point on there is, again, it's an extension of an offer to catch up again at some point around the shared care record and secondary care sort of discharge medicine services. It feels like a long time since we've really mapped how patient data is flowing between secondary care, pharmacy, and what's been happening with GPs. So it's great to hear that the GP systems are being upgraded and they've got really good functionality, but it'd be good to discuss again how community pharmacy links into that and how we could progress that in future.
Yes, absolutely, Lauren. Those all sound like great points. And of course, the digital strategy for the ICS wide area should have been updated this year. It's overdue an update.
Thank you. Really helpful and salient points, Lauren. Any more on this one? No, so again, the recommendation is to note the report. I'm assuming we can all agree that. And I think it's fair to say thanks to you, Anne, from the committee. We really welcome all the hard work that you do. Thank you.
Thank you very much. Thanks, everyone.
Cheers. Okay, that moves us on to the finance and governance section of the agenda. And we have the ICB transition GP practice alignment. This was another one for Sadie. Mark?
Yes, I'm happy to take this one, Ian, if that's okay. So
Thank
hopefully a fairly straightforward paper here. So this relates to the ongoing changes in the NHS, and we're required to review our practice alignment, given that we are going to coming together as a cluster across Norfolk and Suffolk. For us in Norfolk and Waveney, I would suggest this is fairly straightforward, but obviously where in the SNE teams, where the Essex element is separating from the Suffolk element, that it's a little more complex there. So, but we still need to seek approval from the committee to note the alignment of practices to the new Norfolk and Waveney ICB, and that's what we're seeking approval for today. Thank you, Chair.
Thank you. As you say, it's a pretty straightforward report in terms of the geography that we're looking at. The details given at the end in from page 75. Are we happy to approve this?
Yep.
Thank you. Super. So we move on to delivery reports. We've got 3 under this agenda item: the general practice and community pharmacy, dental services, and dental development. Who can help on this one?
The general practice and community pharmacy one's myself, Ian.
Okay, do we want to do that first then? Thank you.
Thank you. I'll take the report as written, but just a few key things to bring out from the meeting. Obviously, there's several elements within there that we've already discussed as part of the PCCC, such as risk and forward planners. But just for a couple of items that were brought for noting, which just to highlight is around the integrated performance report. So we introduced the report to the committee, explaining that it's still under development for ourselves, and we're looking to have a detailed quarterly report on performance against targets and bringing that back to committee meetings. So that was introduced to the committee, and also a sustainable commissioning review of a pharmacy service that was brought for noting, really wanting the committee's input into the discussion, where we discussed risk, transition planning and communication. The item will return for discussion on the final outcome after the input of the group has been considered. And then for approval, several items on there, but one just to pull out is the improvement and support register. We discussed around the pharmacy and GP visit programmes. Initial feedback, particularly on the GP visit programmes, has been positive. And there was also a note to say that there's been a decrease in the number of practices on the registers, with 5 remaining, mainly awaiting CQC inspections. Happy to take any questions.
Thank you. Any questions on this one? No. Oh, yes, Shepherd. Thank you.
Yeah, thank you. Just to echo and reinforce, I think it's really good to see our practice visits program across community pharmacy and GP, and working together, having pharmacy colleagues and also commissioners from the GP actually doing joint visit. It's actually beautiful to see that work. And I think it's getting stronger and stronger. The second point I wanted to make is also, I think it was really good discussions around the estates kind of proactively looking at how to improve the facilities for our practices, especially I think it was the Suffolk area, that they are really making early efforts to find some funding that comes through to expand those, and really good early discussions. And I just wanted to surface that.
Thank you. Anything else on this one? No. Do we want to then move on to the dental services delivery group? Fiona?
Yes, thank you, Ian. So I'll take the paper as read and just highlight a few key areas. The committee noted the progress report on the delivery of Year 2 of the long-term dental plan, and a very brief update is attached as an appendix to this report for Primary Care Committee to note. A number of key decisions were also made by the delivery group, including the finance report and year-end report, which looked at and discussed whether the ICB would be issuing breach notices as a result of underperformance last year. And there is a separate paper coming to committee in part 2 to agree a targeted approach to issuing breach notices. The other thing, the other part that I would draw attention to is that the report also contains the operational plan targets in terms of activity delivery and new patient activity. And whilst the activity delivery target is below where we wanted to see it, month on month this year, activity delivery has been higher than for the same months last year. So there is really positive update on that. And we've also just allowed practices to overperform up to 110%, providing they are seeing new patients. So that will allow those practices who can deliver more activity to offer that support. I'm happy to take any questions on that one.
Any questions for Fiona? Thank you, Hein.
Comment and a question. It's good to see the uptick in activity versus last year, and also the additional unscheduled care. So really pleased to see that, Fiona. I had a question on the first bullet point in the appendix around supervised toothbrushing scheme, where you're working with Norfolk County Council. I was just interested in within what time frame will this become reality, I guess is my question.
So we've been working very closely with Norfolk County Council Public Health team. We've been out to seek expressions of interest, and we have successfully appointed providers. So that's key. Obviously, I suppose we're moving into the mobilisation plan now to move that scheme into actually happening.
Yeah. Okay. Thank you.
Thank you. And do we have Karen? Thank you, Karen.
Thank you, Ian. Fiona, thank you for the report. In terms of the supervised toothbrushing, are we able to target our specific populations where we know that we have increased dental caries? So, for example, I think Great Yarmouth and Waveney and that area springs to mind, but I'm sure there are other areas too. But it seems really important to me when we've read the data about which groups are being impacted.
I think you. Yeah, Karen, thank you. I think you're absolutely right. The national scheme does target schools and early learning centres in IMD areas 1 and 2. So we are very much targeting those children in the higher areas of deprivation. And I think it's also important to note that whilst this is a national scheme, there is an incredible amount of supervised toothbrushing already happening across Norfolk and Waveney. And so this national scheme is actually building on what's already happening. And we also have a large number of providers who regularly go into schools and deliver education and prevention messages. So I think it's great to see a new scheme coming in, but it is very much building on what we're already doing in Norfolk and Waveney.
Thank you.
And if I can just move quickly on to the development group.
Yours as well, yeah.
This is our key stakeholder group that considers new ideas. And the last meeting was in July. And I think you can see from the paper that there was a wide range of topics discussed. But I just wanted to highlight one of the projects that we're looking at is the concept of integrated neighbourhood. health team approach in Norwich, and we're working very closely with the PLACE team and key stakeholders around that. And it's great to see dentistry as part of a wider health and social care approach to health.
Brilliant. And yeah, public health as well, absolutely. As part of it.
Yeah, they are.
Okay, any comments or questions on the development group report? No. Are we then happy to note these 3 reports? Yes, thank you very much. Which moves us on to the next 3 on pharmaceutical ophthalmic services. So the Pharmaceutical Services Regulation Committee.
That would be myself, Ian.
Thank you.
My colleague Greg, unfortunately, who is delayed, who's normally our attendee at the meetings. I think rather than summarising the report, I just take the report as noted. The information is as written, so I would just welcome questions if anyone has any questions around the report.
Any questions for Sharon? No, I think we can note that then, Sharon. Are you going to take the next one as well?
Yeah, we could do both the same. So I think the ophthalmic one, as well as a quarterly report around the contracts for optometry. We need to make sure that we don't confuse optometry and ophthalmology, kept quite separate. So this is the primary care report around the GOS contract, and if there's been any variations on those contracts. But again, take the paper as written, and if there's any questions, happy to take any.
Thank you. Any questions on this? Or can we note this? No. Okay, so let's note that one as well, which moves us on to finance, strategic finance report, month 5. Who's going to take this one? This is a slide pack. James, there we are.
I've been myself. Thank you, Ian. Yeah. No worries. I'll just share my screen just to go through the key page on the slide pack. So this is an update of the month 5 financial position of primary care and prescribing within the ICB. As we can see at the moment, we are reporting a slight overspend on our full year figures of £0.1 million of our £629.1 million budget at the moment. What I'll do is just go through some of the key drivers and variances behind that overall variance, as we can see on this slide here. There are a few areas. So the GP prescribing area is broadly on plan at the moment, with our £14 million efficiency requirement delivering at the moment. We are showing a £650,000 positive variance within the locally commissioned services and delegated primary care subdirectorate. These are operational variances at the moment around the Q1 claims that we have for LCSs that are at the moment slightly underneath our budgeted figures. And within the delegated area, we're seeing benefits from the planned efficiencies of moving contracts from APMS to GMS within that. We're seeing a larger variance within the Optom and pharmacy area. The Optom benefit is an operational one, and there is a reduction in activity on site tests at the moment, and the pharmacy is an efficiency benefit based on the allocation we received on a fair share basis, being less than is required at the moment. As you can see, that builds up to match off against our efficiency requirement of just under £3 million at the moment, giving us our slight overspend in the forecast out term. The pack just does contain some additional details on the individual areas, which you can read through, and also on that LCS position in terms of the Q1 figures that we've received, and you can see the specific schemes that are slightly underachieving at the moment in terms of their activity. So that was all the areas I was going to highlight. If there's any questions at all.
Thank you, James. Any comment or question for James on the money? Hi.
Yeah, comment and a question. So thanks, James. The comment is really impressed with the prescribing efficiencies. I know we have Michael Dennis on shortly, but well done to you and your team. Michael, my question is on the LCS activity tracker. Just a sense, I know last year we had some real outliers compared to budget, but this time around it seems there are some differences, but it seems to be more closely aligned on the whole. So is this more a reflection of last year's experience reflected in the budget, or is there more active monitoring on what's in play?
I think there'll be an element of both of that. So absolutely, our budget will be set on the forecast outturn from last year. So those additional activity will be encompassed in that. I think we have to have a slight health check with that in terms of this is just the Q1 results, and we do know that the LCS figures can be quite volatile. So we do need to keep a very close eye on that, which we do. We monitor that and work with the commissioning teams on the delivery of those areas. So yeah.
So my request when we have a next update on LCS, if there's some real outliers, either positive or negative, it's possible to add a brief comment what the driver of it is. I think that helps.
We could do that, absolutely.
Okay, thank you. Any other comments for James? No. So again, recommendations to note this. So assuming people are happy to do that, which brings us on to the final report, which is on strategic strategic prescribing. And Michael, if you can take us through this one, please.
Okay, thanks, Ian. So a lot of information in this report, as usual. Prescribing a medicine is the most common intervention in the whole of the NHS, and we focus on the quality and cost around various indicators, etc. And we split our work streams into 5 pillars. So quality and safety, which includes dietetics and antimicrobial stewardship, clinical experience and delivery, which is around the sharper end of persuading and facilitating practices to make changes in medicines. Interface and formulary, which is around describing what and is best practice in terms of pathways and choice of medicines, etc., and the commissioning of medicines, and looking at the interface between secondary care and primary care, and population health and data. It's a very data-rich area, prescribing. We can do quite a lot of minutiae, and it's just making sure we're focusing on the bits that are important for our population and dealing with inequalities, etc. And then the key enabler is workforce and some projects that don't fit neatly for anywhere else, which is, for instance, our waste medicines campaign, and hence my backdrop on Teams today. I'll just circle back to pick out one thing and then perhaps focus on questions. So the section 3.3 antimicrobial stewardship is a big part of the strategic work of the medicines team, and looking at areas of variation, unjustified variation, looking for justification if there is some, but usually it's unjustified, and then working with practices to audit and make changes around prescribing. So the latest indicator is part of the Norfolk antimicrobial prescribing metrics for 25-26. So it's a bit of a mouthful. Percentage of children aged 0 to 9 years who have been prescribed at least one antibiotic in primary care in the last 12-month period, which is, and the reason they've brought this one in is to focus on childhood development of immune system, etc. And the more antibiotics you give into younger children, the more disruption occurs to the microbiome, and that does have knock-on effects in terms of development and immunity. So it's quite important. So it's a good lever for change, and my team have been working with public health, children and young people team, Norfolk County Council education team, nurseries and primary care nurses to get the message changed around antibiotic seeking behaviour, particularly from worried young parents, etc. And so the indicator was kind of arbitrarily set at or below 27% of children 0 to 9 receiving an antibiotic in the last 12 months. And that was basically the bottom, as in the lowest and best quartile nationally. And the 12 months to the end of June 24, so the previous year we were 40%. 12 months to the end of June this year with 31.4. And July data is now out, and actually we're 30.6. So we're continuing to go in the right direction and not far off the 27% target, which is good for our population and reduced exposure of bacteria to potentially unnecessary antibiotics, which would increase resistance to those antibiotics over time, which is the ultimate strategic aim, whilst also focusing on children's development, etc. So that was the only thing I wanted to particularly pick out. There's just I'll just mention structured medication reviews we've put into our prescribing quality scheme this year, along with a toolkit. So, as I said at the top, prescribing a medicine is the most common intervention, and stopping a medicine is our strategic aim to get that more embedded into practice. Certainly we're moving in that direction, but it's focusing on a structured medication review which removes unnecessary medicines or medicines that may or may not be maybe doing no good, which is an adverse drug reaction, or actually causing harm, which is definitely an adverse drug reaction, and just trying to get that embedded so that that's almost as common as prescribing a medicine, stopping a medicine. At that point, I'll stop and happy to take comments, questions.
Michael, thank you. Okay. Straight out of the track, we've got Karen.
Yes.
Oh, are you on mute, Karen?
Karen had problems with Teams, but
yes, I'm having problems with Teams.
So we can hear you perfectly well now. Thank you.
Thank you so much. I won't shout and hope the connectivity lasts.
You're absolutely fine.
Michael, thanks so much. And I think it's really important to note with the AMS stewardship that's taking apart how important it is, because often our patients, if prescribed inappropriate or over prescription of antibiotics, can lead to Clostridium difficile, particularly in the elderly, and that is massively challenging and can impact and lead to hospital admissions. For the uninitiated, that is a form of very severe diarrhea that can occur, and it can be toxin related, and it can be really, really nasty. I think also for me, Michael, it's important just to also reflect on the really good practice you were recognised nationally with one particular practice you piloted in, was it Brancaster, where you have named, or another practice?
Near Burnham Market, yes.
Burnham Market, I knew it was a B.
Yeah.
And you'd had particularly good, you'd worked really well, and you were rolling that out in a number of other practices to look at that particular initiative. I didn't know whether you wanted to mention it here. Thank you.
That's a good one. Certainly Burnham Market were a bit of an outlier nationally at one stage in terms of broad spectrum antibiotics, and we worked very closely with the practice and the dispensary team, particularly in helping identify key drivers of that and promoting change. And it took a little while, but we had a major success there, as you've pointed out, which is very gratifying. And we are continuing to work with high prescribers of broad spectrum antibiotics, which have if prescribed widely, have the most detrimental effects on antimicrobial resistance. So, and also, as you mentioned, C. diff, Clostridium difficile, which can be fatal. Let's not beat about the bush. It's very nasty consequence of one of the drivers being overuse of antibiotics. So we're continuing to roll that out through that team. Thanks.
Thank you.
Thank you. Next, come to Lauren.
Yeah, I wasn't sure from the report whether, Michael, you've got access to some of the Pharmacy First data around prescribing and treatment options that have been used in community pharmacy, because obviously we're kind of working to the same purpose in terms of how and when antibiotics are accessed by the public. And I wonder if there's a piece of work to do around those who are trying to access or seeking antibiotics being diverted to their pharmacy for assessment for the suitable conditions, because we know that working to a PGD is a lot stricter set of criteria around when and how you can give an antibiotic than, you know, obviously what you can do on a prescription. So things like length of treatment as a focus and, you know, the comeback if it's not resolved are very much embedded in the pharmacy first pathways. So could be a really good driver for modelling the right behaviours, so to speak, in patients that are looking for antibiotics. If they come see their pharmacy and have a consultation, go through all the red flags, etc., that might be a encouragement of them not to always keep picking up the phone to the GP and saying, I want antibiotics. So I just wondered if that's something we could work together on. I know Sharon's certainly got access to a really good resource of all the data, and where you've got issues with over prescribing or you've got cohorts of patients that could overlap, that would be a really good quick win, so to speak.
Yeah, thanks for that, Lauren. I mean, the data is a little bit limited, but there is quite a lot of it, and turning it into something useful would be potentially beneficial. I'm going to say we could certainly have a look at that for the next strategic report, and perhaps work with Sharon to sort of triangulate the information that we get from there, because it'll require a little bit of nuanced interpretation, I think, in terms of numbers and postcodes, particularly because there's quite a lot of factors why patients might go to a pharmacy more than their surgery, and certainly pointing them in the direction of pharmacy first would be really key, and is a good strategic aim for the system. And I know that's going to be raised at the Prescript conference next week. I don't know if anybody's going to that next Tuesday. There will be a feature about, you know, nudge theory and getting people to the most appropriate place, which usually isn't A&E if you potentially need an assessment for an antibiotic. So definitely keen on promoting pharmacy first, looking at the data and thinking about the nuances of what it actually means, and then turning that into some information that can help us target messages and work with pharmacies. Definitely up for that, and I'll perhaps get some time with Sharon before the next report. Yeah.
Thank you. Any other comments or questions? No. So again, recommendations to note report. I'm assuming you're happy to do that. Yep. Thank you. That moves us on to any other business. Do we have any questions from the public? Nothing emailed in. No.
No, I haven't had anything from John Punt, Ian. No questions.
Okay. All right. Thank you. Does any committee member have any other business they'd like to bring to our attention? No. Okay. Well, you've got almost half an hour of your life back that you weren't expecting, such is the chair's largesse. So thank you all for keeping. Oh, Mark.
Just a thought, Ian. Is it worth bringing forward the start of the next meeting?
I'm happy to do that, as long as there aren't other people on the call that, or not on the call, that will be expecting to go to
I can send an email round to part 2 attendees.
Shall we suggest 3 o'clock then? If we reconvene at 3 o'clock for part 2. For anyone who's not attending part 2, thank you for your time and attendance and contributions this afternoon, and until 3 o'clock, a very good afternoon to you all. Thanks a lot.
Thank you.
Thanks.